and Medicine Science, Vulvar Cancer and Precancerous Lesion, Joint Secretary, Hyderabad Menopause Society, Program Director, Fellowship in Advanced Gynec Surgery, KIMS Kernel, Sikandrabad, Life Member of FOXY IH AGRS. We welcome you, ma'am.
Good afternoon, everyone. I'm just right on time. This is something, my topic is the forgotten breast after 45. I will talk on density implants, pain, and fear. I would not cover the cancer breast, but other than non cancerous lesions and complaints, we would be covering that. This is my alma mater, Pandit JNM Medical College, though I was born in Bangalore, but I call this Raipur as my birthplace. Bring greetings from Kim's Cuddle, Sikandrabad. Breast pain. This is an extremely very common, frequently linked to perimenopausal phase. This is mostly because of the fluctuation of the cyclical pain comes because of the fluctuation of estrogen and progesterone. Non-cyclical focal pain that really requires lot of assessment. Now, if a lady comes with breast pain, should we how do we go forward? Most of the time, assurance, their concern is basically, is there any cancer? They come with the question first. That way, most of the pains that is manageable with fomentation, anti-inflammatory, good support. So when do you evaluate breast pain? It is if the pain lasts for more than 2 weeks. Pain in that region could be because of the breast causes or non-breast causes. Non-breast causes because of the skin, connective tissue, muscle, rib inflammation, heart, lung inflammation, or any of the lesion in the lungs. Mastalgia, new onset, premenopausal and postmenopausal mastalgia should not be dismissed. Causes are basically infection, inflammation, trauma, drugs, and malignancy. Diagnostic imaging is often appropriate. So here we can see there are different structures right from skin. The breast tissue itself consists of suspensory ligament, lobules, milk ducts, fat, muscle. So there could be lesion in any of these. When to evaluate? Mostly with good support, heat and cold therapy, dietary changes. If it lasts more than 2 weeks, yes, we need to evaluate. So check for any sort of new lump, thickened area in the breast, underarms, nipple discharge, all has to be seen. Dense breast. Why do we call breast being dense? This terminology came from the imaging that mammogram, the picture shows as a dense breast. So dense breast tissue is normal and commonly it affects about 40 to 60% of the women. Common imaging modalities, high resolution ultrasound, mammogram, MRI. Dense breast tissue refers to the way breast tissue looks on mammogram. Breast cancer, why is it of so much significance? Because the lesion is dark and any cancerous lesion on mammogram appears as a dense lesion. So if the tissue is dense, the lesion may be missed out. So that is why the routine conventional mammogram may not give you the proper result on that, in which we require 3D imaging. So breast cancer, which also looks like a solid white on the mammogram, could be missed. Newer 3D mammogram technology helps in such situations. Additional MRI may be required, that is breast tomosynthesis. Breast implants. Implants were like coined in way back 1957 when women were getting mastectomies done and they were like going on for the implants. But in 1997, they came out with FDA approved proper medically designed implants. And that was basically started for those who have undergone mastectomy, were going reconstructive surgeries. Later in the a few decades, it has become as a cosmetic surgery. So even young girls of any age group, they are also undergoing these breast implants. Females with breast implants require continued follow up. First of all, the surgery is done by the plastic surgeon, but the woman first approaches gynecologist. That is the reason why we should be knowing more about the implants. Enhancement methods like the breast volume adjustment, breast lift, breast implants, autologous fat grafts. So, one, the implant could be put fixed before the, above the pectoralis minor or between the muscles also. Breast implants, when enhanced by an implant, we need to know what all things. We need to document type of the implant and location, educate self-awareness check, abnormal breast examination, swelling, redness, pain and mass. Baseline mammogram after 6 months of the surgery is very, very important. No conventional mammogram, only MRI, MR mammogram is advised, because what happens? Compression of the breast tissue that will further, damage the implant capsule. So, what all things to be taken into consideration? Look for capsular contracture, implant rupture, need for the implant exchange after 10 years, pregnancy and aging changes also will happen. Breast implants, when to seek immediate attention: sudden significant swelling, inflammatory changes, fever, persistent pain, sudden change in the shape. These are the conditions where we need to be aware about. So, when the breast is implanted, endogenous bacteria, that infection will further give rise to contamination at the site of the surgery. Role of the bacteremia: it will form an biofilm around the capsule, and that will further lead to contracture of the capsule of the implant. So there is chronic infection and there is also risk of the cancer. So aftermaths are capsular contracture, excessive hard scar around the implant. Aftermath: implant related malignancy, breast implant associated anaplastic large cell lymphoma. Strongest association is with the textured. We have two types of implants. One was the smooth one, the other one was the textured. Then we came out with capsulated, non-capsulated. The non-capsulated were like they would the silicone material would infuse into the connective tissue, and that would further lead to the capsular infection and contracture. So the strongest association is with the textured surface implants, very rare, 1 in 30,000 after 10 years. Capsulectomy or chemotherapy, only 56 deaths have been seen world over. About 2 million undergo breast implants each year. Autologous fat grafts, baseline mammogram after 6 months, regular breast screening like anyone. The fat graft can get calcified also. Now we move on to the next symptom, like nipple discharge. How is the approach? The woman really gets scared about any discharge coming, and they are very apprehensive about it. So we need to make them understand whether it is physiological or pathological. Physiological, it is bilateral, multi-duct, non-spontaneous discharge. Pathological is like unilateral, single duct, bloody discharge, serous discharge. Breast examination is very, very essential. Nipple discharge, red flags concerning features: spontaneous, unilateral, single duct, bloody discharge, or serous. Associated mass or skin changes increase concern. That requires imaging and the specialist assessment. Bloody discharge, associated mass, skin nipple changes. Persistent unilateral spontaneous discharge warrants imaging. Ultrasound mammography depending on the age and the risk. Consider duct excision, specialist referral whenever indicated. Skin changes of the breast, most common, we have been reading since undergrad, pudy orange, skin thickening, dimpling, retraction. The skin changes could be eczema like nipple lesions that may suggest Paget's disease, persistent erythema, swelling may indicate inflammatory breast cancer, prompt imaging and referral is required. So, the different skin changes could be discharge from the nipple, growth of the veins, the engorged breast veins, pulling or puckering of the skin under the tumor, redness, hot skin, swelling, recess, or there could be retraction of the skin because of the growth, resize one of the breast tissue, the obvious asymmetry, retraction of the breast nipple, sealing tumors, thinning of the breast skin, retraction of the skin on the chest, destruction of the skin. So these are the different, and we need to be really very vigilant and alert about it. Family history and patient anxiety. Obtain a 3-generation family history when possible. Identify patients needing the genetic counseling or testing. Address anxiety and risk based counseling has to be done. Breast cancer risk, family history, patterns that raise red flags. Most common, more than one relative with the same type of the cancer, maybe the aunt or sister, any of the close family members, and family member with multiple cancers, family member with cancer atypical for the sex, cancer in any of the in both one organ. So these are the you should be highly suspicious of all these lesions and advise them and counsel them accordingly. When imaging and specialist referral is needed, refer for the suspicious imaging, palpable masses, pathological discharge, or high risk history. Use age, symptoms, and risk factors to guide imaging modality. Nipple discharge, as I already told you, pathological, physiological, and proper breast examination is most important. Breast imaging, high definition ultrasound versus mammogram. Ultrasound referred in is preferred in younger women and focal symptomatic evaluation. Excellent for cystic versus the solid lesion characterization. Mammogram, primary screening tool in appropriate age group. Breast imaging depends on the age, symptoms, and the breast density. When we were about a decade back, the cutoff age was 45 years, but according to ACOG and newer guidelines, they have set the age of screening can be done mammogram as early as 40 years. Mammogram guidelines, FOXY and Breast Society of India guidelines, starting annual screening mammogram at the age of 40, average risk, annual or biennial screening between the age of 40 and 70 to 74. High risk individuals, women with strong family histories, genetic predispositions, BRCA mutations, or previous chest radiation should begin earlier. So these are the high risk group where you need to be cautious about screening for the breast, often by the age of 25 for radiation exposure, and undergo yearly mammogram or the breast MRI. ACS guidelines, what it says, ages 40 to 44 years have the option to begin annual screening. 45 to 54 years recommend getting mammograms every year. 55 and older can transition to every other year or continue yearly screening. Exact age and frequency vary depending on the health organizations. AI based risk assessment on the routine mammograms are assessed. Choosing the right imaging modality. We need to ask ourselves how much are we justified, in advising mammogram. Many of the labs, if they go for the master health checkups, they have randomly advised for women even above 35 years for the mammograms. So that is what we intervene, and we need to decide, yes, high resolution ultrasound is equally informative, along with the, it has same sensitivity like the mammogram. Choosing the right modality, more than 40 years diagnostic mammography often combined with ultrasound, MRI reserved for selected high risk patients or implant evaluation. Birat's classification has been really, really helpful. That is the breast imaging radiation data systems. What it says is additional imaging is needed, which is Birat's 0, Birat's 1 to 2 negative benign, Birat's 3 probably benign, less than 2% risk. Why we need to know is because we can explain to the patient the risk assessment for that particular individual. Short interval follow up. The patient can be called for follow ups more often depending on the risk. Birat's 4 to 5, suspicious, highly suggestive of malignancy, biopsy indicated. Birat 6, yes, known biopsy, proven malignancy. Now, this is a very beautiful slide. What it says is mammography sensitivity. You see the picture of the breast, which is showing predominantly fatty, where the picture is very, very, it is showing a gray image as the tissue becomes more and more dense. So, here you see the sensitivity is around 78%, and that is further reducing, the sensitivity reduces by 47% as the breast tissue becomes more and more dense. So percentage of women under the age of 45, about 4 to 5, 4.2%, they are below the age group of 45 years, whereas heterogeneously dense, the group of people around 43%, and percentage of women over the age of 45 years is almost about 9.8%, and the maximum group is scattered, fibrogranular, and heterogeneously dense. So there are two different scenarios. One is postmenopausal mastalgia, 58-year-old with new focal breast pain, clinical examination, normal breast, diagnostic imaging recommended. The most important point, new postmenopausal symptoms warrant evaluation. So, when to seek medical attention for breast pain in menopause, like fever, family history of breast cancer, lump, nipple discharge, dimpled, rash, or thickening of the breast. Another scenario with a bloody nipple discharge. So, here is a lady, 45-year-old with spontaneous unilateral blood discharge, no palpable mass, cytology of the fluid from the nipple to be taken, diagnostic mammogram, targeted ultrasound, and specialist referral. This, depending on the discharge, is like the white, clear, or cloudy breastfeeding, galacturia, hypothyroidism. These are depending on the discharge. If it is a white, lactating woman can also be there. Yellow, that shows hormonal fluctuations, infections. Green, brown, duct ectasia, intraductal papilloma. Red and pink, again, you have intraductal papilloma or breast cancer. So, key OPD pearls, what all we all need to be aware and be vigilant about is most breast complaints are benign but required structured assessment. Recognize the nipple discharge and skin change red flags. Choose imaging according to the age, symptoms, and risk. High resolution ultrasound and mammogram. Use BIRATS to guide management and the referral. So, key take home messages, just a last slide for me. Most breast pains are benign. Recognize the red flags, tailor imaging, and referral to the symptoms and risk. Thank you for the patient hearing. I thank the organizers, Dr. Asha Jain Madam, Dr. Jyoti, and all my colleagues, our president, Sandhya Dikshit Madam, who gave me the opportunity to talk here. I thank everyone for this. Thank you.
Thank you, ma'am. Thank you, ma'am, for such nice slides. I want to share one this patient, ma'am. She come to me. She is 2 months postnatal. She is having left side breast milk is white and right side breast milk is having blood tinge. I went for evaluation and also sent the culture. Culture came to be Escherichia coli, but nowhere it was relevant because TLC counts everything were okay. And when I went for scanning and all, it was showing intraductal papilloma. But then patient do not want any further treatment. Matlab I explained the risk, but then now they are afraid. They don't want any further. Matlab, how to deal with such cases, ma'am?
Uh, Yeah, such patients, you just need to keep them under follow up. Don't let lose, sight of that patient. You can just keep on every, the first visit is they are really very anxious. As they understand and you show them, it is a very normal thing. And yes, we have seen during lactation time, the one side of the breast may show blood thinns. So what I feel, it could be physiological because of the increased vascularity of the breast also. The thing is, you keep on calling her, do the follow up for the next 6 months, and she herself will be convinced as to yes. And yes, what happens is they go to the labs, then they get the mammogram. This is all where they go off track. So we need to instill that confidence. Everything is normal, make her understand, and do the follow up scans, or if required, cytology after 3 months or 2 months. That should be fine.
She's not feeding from that breast. Matlab, not nursing
Yeah,
from
not
that.
necessary. So if she's not feeding, you can, if the discharge is still coming, just a course of antibiotics should help because all the lacticiferous
Yes,
ducts
ma'am.
are
That's why I was anxious. It's not
okay.
helping. And
Okay.
she do
So
comes, but
duct ectasia is a common type of, problem we come across. And excision of that duct ectasia, that can also help you. And it need not be always a surgical intervention. Most of them, they subside by themselves.
okay. Thank you, ma'am. Thank you
Thank
so much.
you. Yeah.
Actually, I feel all should come to that.
Nice, madam. Thank you, madam.
Fantastic.
Thank you,
Chala
madam.
very nicely rushed back.